Good afternoon, everyone, ladies and gentlemen, distinguished delegates, dear colleagues. Welcome. Welcome to the Maison de la Paix. I'm going to start by a little challenge. I want to challenge you to find a side event that you've ever attended that is co-organized and sponsored by Switzerland together with South Africa, together with the EU Commission. We don't get this every day. So this is a very great honor for me to be able to welcome you all on behalf also on South Africa and the EU Commission. The underlying idea for this side event was to highlight some of the tangible results we have achieved in the context of the long-standing WHO agenda item called Fasten Your Seatbelt, and I quote, follow-up of the report of the Consultative Expert Working Group, Financing and Coordination of Health R&D, brackets closed, known by everyone in the room, CEWG, which basically, whenever I have to explain this to my Federal Councillor or State Secretary for Health, they go, what? Okay. But having said that, Switzerland has been very strongly engaged in this field for the last 10 years and more so, and supported some of the key elements presented today. And the Global Observatory on Health R&D at the WHO, the Product Profile Directory, and the groundwork for potential pooled fund for health product and R&D have been some of the top priorities on our list with my colleague Alex Schulze in the room, who is from the Swiss Agency for Development Cooperation. Our rationale for this engagement is embedded in the Switzerland's commitment to ensuring equitable access to affordable quality medical products. And this is a key goal of the Swiss foreign health policy. You may know that Switzerland was the first country to ever adopt at governmental level foreign health policy in 2006, that we have reinforced in 2012, and that we will be reaffirming in 2018. We consider our support to health R&D in areas affected by market failure as a parcel of our engagement for better access. And so for us it is clear that without new affordable and quality medical products, there is no access. This is why we invest in product development partnerships such as DNDi, MMV, and FIND. Having said that, however, on the pathway from successful R&D of a new medical product to its appropriate use by patients, there are many other factors on both the supply and the demand side that potentially affect access. And this is why we support as Switzerland different complementary initiatives along the access pathway. Let me give you a few examples. Our National Medicine Regulatory Authority contributes to strengthening the regulatory systems and networks in sub-Saharan Africa. And under the technical coordination of WHO, Swissmedics support the implementation of the African Medicines Regulatory Harmonization Initiative through technical assistance in joint dossier assessment and inspections of good manufacturing practices. We also work through the global network providing for health, and our Agency for Development Cooperation supports low and middle income countries in their efforts to develop appropriate health financing strategies and to provide social health protection for their citizens. Because even the most affordable medical products need to be paid, which requires sufficient domestic resources. So turning back to the topic of this side event, in light of the stagnating or even decreasing public fund for R&D in areas affected by market failure, we need to make smarter R&D investments and therefore more evidence-based priority setting taking into account all of R&D needs across different areas is required. AMR, emergency preparedness, and poverty-related diseases, all of these require attention. And this is why I'm very much looking forward to the conversation we are going to have this afternoon with our distinguished panelists. Before I invite the first speaker, I would love to ask my colleague from South Africa, Lindy Makubalo, who is an advisor at the Department of Health of South Africa, to come here and say a few words of welcome. Thank you and enjoy our side event.
Thank you, Tanya. My job is going to be much easier because I don't really have very much to say except to thank the partners. We, South Africa, felt that we wanted to partner in having this side event because we have been, as you know, quite keen on the area of R&D, and we really feel that we need to make progress with this agenda, and I think when it comes to the agenda item in the Assembly, it will be quite interesting for us to assess how far we're going. But I think this is going to be an important side event to move us forward. So basically to say South Africa is fully committed, very keen to work with everyone in terms of this work. And also, probably more importantly, I wanted to apologize on behalf of Dr. Anben Pillay, my colleague from the department, who unfortunately couldn't come. He's in South Africa at the moment, and I was hoping that Precious Matsoso would be able to speak, who's our DG, that she would be able to come, but she's also committed some. She was also unable to come because of some other commitments. So I think I would just like to say, because we are not going to then have a presentation, just like to say that South Africa has been, in a sense, certainly for developing countries, a leader in research and development for many years, going back many years. However, it has been quite clear that our work has not really been needs-driven. A lot of our early work in the 60s, 70s was really focused on diseases, conditions that we didn't consider necessarily priority or weren't priorities for South Africa. But we are moving forward, and I think that with the global move in terms of focusing our work, trying to focus our resources, trying to focus our energies, I think many of you would know some of the work that is ongoing now, some of the work at the Medical Research Council, the Center for Industrial Research, which is actually coordinating one of these 6 demonstration projects. I think it's the one on malaria and nanotechnology. So we are investment, but I think probably what we are probably known best for is the work that we're involved in around HIV and TB. So just to say that we're really keen to continue investing as a country in research and development and seeing that we can impact on the conditions that affect our countries. And through the MRC, the MRC is largely funded by government. Through the MRC, we're also trying to support a number of initiatives. There's one that I wasn't so familiar with, and I wrote it down here because I was just talking to Precious and some colleagues who are working in GARDP. I don't know how you pronounce it, GARDP, Global Antibiotics Research and Development Partnership, and I understand that we are significant funding has been put to this project and many others, many other initiatives. So we do apologize that we don't have a presentation on what we're doing, but I think there'll be lots of opportunities to talk about it. But just to say, we're part of this. We certainly want to put more funding and more energy into what we're doing as South Africa. So thank you very much, and our apologies for not being able to fully participate today.
Thank you, Lindy. So it is now my great pleasure to invite to the podium Martin Howell-Friede, who is our keynote speaker. Martin has been coordinating R&D for many years in the private as well as in the public sector. And he works for WHO. He coordinates initiative for vaccine research. But more importantly, one element that really drives him is how do you translate the whole research area into the development? And this is what he will be focusing on. Martin, thank you.
So thank you, Ambassador. When I was asked to talk about this topic, somebody sent me a document titled CEWG, and I went, what's that? So we've known about fragmentation in the R&D landscape for a very long time. For years, those of us that have been around, like I have for many years, know that most of the investment in R&D has been driven by market forces. So this was first really documented in the 1990s, when we came up with the term of fragmentation of the R&D agenda, when we've discovered, or finally first documented, that only 10% of the world's R&D investment was being spent on the needs of the developing countries, which corresponded to 90% of the world's needs. So this really, at the time, in the early 1990s, became known as the 90-10 fragmentation. Now, this then led to the term of neglected diseases. But to be fair, this wasn't only neglecting the diseases of the developing countries. We also saw that even in the industrialized countries, some diseases were not being invested in according to the disease burden that they would represent. I'll give you an example. So prostate cancer and pancreatic cancer have roughly both the same burden of disease. And yet prostate cancer gets nearly 10 times the investment. And this is probably because people put their money where they think they're going to have a success, whereas pancreatic cancer still remains, for many researchers, a rather elusive target. So we've said that R&D has been driven by market forces, not by needs. But when we look at where the money goes, it also the total investment depends on a function of where in the pipeline the product is. So funding a phase 3 clinical study for a tuberculosis vaccine will cost probably between $50 and $100 million. For that, you can fund 100 phase 1 studies of other vaccines. So just looking at the numbers does not matter. So when we look at what's been causing this, we see there's been a fragmentation, or shall we say a lack of coherency, in the money that governments and funding agencies have been putting into research. But there's been another insidious little event. And if we go back a long time ago to the US, to the Bayh-Dole Act, the Bayh-Dole Act essentially gave university professors and researchers the ability to become owners of the patents that they took part in. So this then led to the situation where a lot of researchers that previously were doing research for the good, suddenly they started saying, hey, I can increase my retirement plan by filing a patent. And as a result of this, we saw a huge increase in the number of patents. So within WHO, we did an analysis of who owns the patents around a number of the problems or the diseases of developing countries. So we looked at the vaccines for TB, HIV, and malaria. And if we go back 20 years ago, these patents were owned about 50% by the private sector and about 50% by the public sector. But now they are owned partly because it's been the public sector driving the research, but also because the people involved in research have been taking out patents. We now have about 90% of the patents in the public sector compared to 10% in the private sector. Well, you could say, so what does this matter? What matters now is as we try and translate from research isn't a product, research is just an invention, an idea. As we translate this from the idea to the product, this has to go through the translational research groups, biotech companies, big industry. And each of these now has a huge challenge of negotiating a minefield of patents that have arisen out of the increase in patenting which are being done at upstream at the university level. So this has created a barrier. So even when industry wants to work on these, we see that in many cases they are struggling to pull together the necessary patent portfolio. Well, what's happened in the last 35 years since 1990. Things have actually got a lot better. First of all, in those days, we didn't really know who was spending what on research. Since then, we have a few resources. I mentioned the G-Finder as one, which gives you some information on who is spending what on research. But this information is aggregate. It is not down to details of whether this was a phase 1 study or a phase 3 study, because as I said, this makes a big difference. We've got better awareness of where the needs are, so we actually have some idea of what the burden of disease is. Previously, we didn't really know. There's more funding in some areas, especially from the big donors. Here I specifically cite the Gates Foundation as really putting in a huge amount of money into areas which in the 1990s were not funded. There's more product development partnerships, so this brings the industry into the product development early on, bringing expertise, because previously there was a huge gap between the research and the product development. But also, to try and overcome the market forces, we've introduced incentives. So there's incentives such as the priority review voucher, there's prizes, there's advanced market commitment. They're not nearly adequate enough, but we've come forwards a bit. We've got patent pooling mechanisms. And here in Geneva, we've got the Medicines Patent Pool, and we've got the WIPO research activity, which tried to at least overcome some of the barriers that were developing as all of the researchers developed patents. We've got approved awareness of patent licensing by universities. I've had the opportunity several times in Switzerland of helping universities try to sell their malaria patents and say, why do you want to sell this? And say, well, we can get money for this. This is worth a fortune. And it's very difficult trying to convince the universities that actually selling a malaria patent is, first of all, not going to make them a fortune, but also they're creating more of a barrier than they're trying to solve. So universities are at least now getting some concept of how these patents should be licensed to ensure access to products. There's more developing countries that have manufacturing and R&D capacity, specifically India, China, and Brazil, have really, over the last 30 years, developed their capacity enormously. So the challenges that were in their countries are bit by bit being handled internally. And South Africa, where I did my PhD, in those days we had, I'll give the example of Chris Barnard doing the first heart transplant. As was mentioned, this was not really intended for the needs of the South African population. Now we have focused research in South Africa, focused development, and we have companies in South Africa that are taking the local inventions and turning these into products for the local population. And then I will mention, just once, the Consultative Expert Working Group, CEWG, which began in 2011 to try and gather the information on what this 90-10 gap was and how we're proceeding with it and what to do about it. So where are we now? The prioritization, unfortunately, we've had a lot of progress, but the prioritization is still ad hoc. There is no alignment between the funders. So people are still looking at the burden, the need for new products, and the existing R&D. What we've seen is that you've got to think beyond this. So I'll give an example. A few years ago, I was with Vazi, who will talk after me, in a meeting, and we were discussing vaccine prioritization, and the word Ebola came up. And we looked at our prioritization methodology and tool, and we said, no, that affects about 100 people per year. No. So we didn't work on it. Now, fortunately, there were some Canadian researchers funded by the government of Canada who were clearly not listening to us at all. And they went ahead and they developed an Ebola vaccine and some Ebola therapeutics, very fortunately for us. So the other thing is that funding still tends to go to the most promising products. Some diseases get a lot and others get very little. So this is incoherent. So where are we getting to now? So the data that we have is still insufficient. We don't really know who is funding what, and very specifically, we don't know precisely what they're funding on. So because of this, WHO has set up the observatory, which Vazi will address after this. The other problem is that as companies are developing products, the goalposts are not very well defined. Do we want a vaccine that is going to prevent the disease? Do we want a vaccine that's going to prevent severe disease? Do we want one that's going to prevent death? All of these are different targets, and industry has a great challenge actually making products if they don't know precisely what it is that's wanted. So this comes down to what is now called the target product profile or the preferred product characteristic. And WHO has also begun to set up a directory of these, and Rob Terry will be talking about this afterwards. So finally, how does this link to the Sustainable Development Goals? So I'm afraid when I also said, well, this title of my talk contains SDGs, how do we tie these together? So SDGs are essentially around getting universal healthcare coverage, getting access to medicines for everybody. So this includes the concept of affordability. So we first have to have the products become researched and developed and made available. But once they're available, they need to be affordable and accessible. And this is going to require delinking the entire cost of research from the cost at which they are made available to the population. So WHO in 2013 adopted the resolution, WHA 6622, which has already been alluded to improve the monitoring and coordination of R&D, which Vazi will talk to establish a committee to provide technical advice on prioritization. On what basis do we prioritize these? And importantly, to ensure sustainable funding for health R&D. So that's where we are. We're going forwards. The WHA right now will be receiving the report on the CWG of how far we've got with these. So I would like to finish by suggesting that we have made a lot of progress over the last 35 years. There are many more diseases of developing countries that are receiving research funding, but unfortunately, there are some diseases which are receiving less funding. Much more of the funding looks not only at the research, but also at development, because previously development was not taken into account. And we could have a good research taking place, but there's no way to translate that research into a product. Funding has become available to subsidize essential products. The clear example of this is Gavi, subsidizing the vaccines for low-income countries. And industry is much more involved. However, the reality is market forces still dominate health R&D, but the impact is less than it was. And what we are seeing in developing countries is the need to bring greater coherency in between their industrial policy and their health policy. Again, to go back to my example in South Africa, it is much more viable in South Africa to build a factory to make an erectile dysfunction drug than it is to make a vaccine against tuberculosis. And this is the incoherency between your industrial policy and the health policy. That industrial policy says increase GDP, health policy says let's try and treat the population. So we still have many diseases without affordable access in parts of the world, and this needs to be tackled. So we've done better, but I'd like to finish by saying that good is not good enough when better can be done, and we can do better. Thank you.
Thank you very much, Martin. I would encourage you to write down your questions. We will have the panel conversation afterwards, and we'll dive into the questions, and we have time to have a very informed conversation. Vasi Morthy is working also at the World Health Organization. He's coordinating research, ethics, knowledge uptake, health systems, and innovation cluster. When I asked Vasi what is it that really drives him in his work, he said, I'm really convinced that everything should be done not based on the passion for R&D research, but based on the needs of public health. And this is what drives him. So Vasi, please welcome.
Good afternoon, everyone. So I have not been intimately following the CWG agenda for the last X number of years. I didn't say when I saw the title, because I don't speak like that, but I had, I was internalizing the same sort of feeling. But what I'm going to try to do here is, in 10 minutes, try to cut through the terminology to the core of what we're trying to do and why I think this is a real opportunity that we have at the moment. So where we are with the political discourse at the Assembly and the Board, and everything that we're doing is at the instruction of our governing bodies and with the support of our donors, without whom we couldn't do this. We are starting from the public health objectives, where the burden is greatest, and we are going through a comprehensive health R&D mapping process that leads into a set of disease-specific analyses that will then feed into the expert committee on health R&D priority setting. So between the Global Observatory on R&D and the Expert Committee on Health R&D Priority Setting. This is, for the first time, a mapping, analysis, and priority setting in health R&D process by which we're going to be generating a template standard set of information so that we can have really thorough, comparable, evidence-based priority setting, starting from the public health objective and always with the end-to-end perspective on linking the R&D to what we need. So this relates to entirely new products, but also better uses of the products that we have at the moment. So the Global Observatory on Health R&D is our centralized and, in my view, if anybody knows knows better, then I'd like to know. But as far as I can see, this is the single most comprehensive source of health R&D information that's available, because we are working with a very broad, rich tapestry of collaborators, each one of which is the best available global source of information within their functional area. And we're essentially aggregating all this information. And we're doing this to map and synthesize health R&D activities to enable evidence-based, and I think that's very important, R&D priority setting, because the people will only follow and understand the R&D priorities so far as they understand the rigorousness of the process and the evidence base for that process, which will be presented to this newly constituted expert committee on health R&D. Target users being governments, policymakers, funders, and researchers. And if there's one thing I'd like you to do after this side event, is please do go to this URL, because the visualizations that we have, we cannot do justice to them with static pictures. They're all interactive. You can interrogate them in various ways. So who.int/research-observatory. The background is that we have two World Health Assembly resolutions in 2013 and 2016, which mandated and emphasized the central role of this new R&D observatory. And then we also had, in a resolution from last year, a request from the Assembly to establish the Expert Committee on Health R&D to set priorities for new investments based on information primarily provided by the Observatory. There are some other resolutions which also refer to the Observatory, and as is maybe not surprising, a couple of the points that the themes within the broader health R&D space that have been picked out by our governing bodies are the importance of ensuring that we provide information to guide R&D investments in the AMR agenda, as well as the emerging pathogen agenda, with what we call the R&D blueprint for action to prevent epidemics, which is something I'm also involved in part of my work. The scope, I'm not going to go through this definition of type 1, 2, 3 diseases. It's essentially focusing on the needs of developing countries, but not only developing countries. So there are some R&D needs and disease conditions which are problems everywhere. So this isn't only about developing countries, but the focus is on health needs for where the disease burden is greatest, which is often in developing countries. Clearly, market failure is one important aspect of this, and in the analyses that we're going to be developing, we're going to be exploring the different types of market failure and possible ways of attempting to overcome these. And as more data and resources become available, we're going to be expanding what the observatory provides. So it's clearly the observatory is building on existing data. We cannot be replicating and repeating unnecessarily what's already been done well by others. Rather than that, we've reached out, and our team, led by Tagreed Adam, here working with other colleagues, have been reaching out to many groups around the world and accessing existing global databases. But in some cases, we have found that we are going to need to have to gather new information ourselves where it doesn't seem to be being collected elsewhere. Everything that we're doing is working very closely with our technical department. So as we work in TB, malaria, HIV, NTDs, other areas, we work with the relevant groups across WHO, because we are starting as a basis for the analysis that we will be providing with what already is out there in that landscape. So we're essentially amplifying the existing work that's been done. But what we see when we talk to the technical departments is that they see this as a real opportunity, because what normally happens in the WHO discussions, if you're working within a disease space, is you have a disease program which is either focused on control or elimination or a combination of those in different settings. And there will be an R&D discussion, but it's somewhere down the list. It's primarily focused on implementing, etc. And then if you look at the global strategy documents, there'll be a section on R&D, but it's whenever there's a meeting, a high-level meeting, it starts off with the discussions about implementation, and then you try to find space and energy for the R&D discussions. This is flipping that around so that the lens is what are the R&D needs in order to meet the public health goals. If we have the agreed strategic public health objectives, what are the tools and strategies that we have to meet them? What are the limitations of those? What are the projected threats to the existing tools, such as emerging resistance, which everybody sees as a major problem in almost everywhere where we're working? What is the pipeline? What are the investments that are coming in? What are the market issues? And from all of that, what is the gap analysis that leads you to really a comprehensive set of R&D needs? So this is a real opportunity to do that in a comparative way across different areas. These are the collaborations that Tagreed and others have been working on, and I just wanted to highlight some of these. So one is ICTRP, which is the International Clinical Trials Registry Platform, which I think is a woefully underused resource at WHO. We have, so going back to 2005, we have core standards for how all clinical trial registries should provide information on the methods of clinical trials. And we have agreement from 17 of these registries, including clinicaltrials.gov and the EU-wide registry, Chinese, Indian, ISRCTN, Pan-African, Brazilian, and many others, to import all of this information in a centralized way that allows you to query this. So we have over 420,000 clinical trials. Over 2,000 clinical trials are imported every month. And the observatory is allowing us to amplify the usefulness of this information, and there's a new visualization based on that in the observatory. We're working with multiple different partners on the product pipeline, aggregating information across different diseases and different product classes. GFinder as the single best comparative source of information that we have on R&D flows for neglected diseases R&D, and with the definition that they have. The OECD UNESCO source on health researcher capacity, and many others. We're expanding into other areas, working with all of these groups, Wellcome Trust, NIH, the European Commission, the Gates Foundation, and TDR, because we're going to be incrementally building up the sorts of information that are in the observatory. This is when you go into the interface, this is at the high level how it's defined. At the top here, between the monitoring, benchmarking, and R&D indicators, these are visualizations with different axes that allow you to see different facets of the R&D information. They're based on these global databases that we're aggregating, and you can directly see the global databases here. These are the disease-specific analyses and syntheses that we're providing. And I think a very important secondary outcome, which in the medium term I think will itself have big benefits, is the work on classifications and standards, because when you try to provide globally available information across different product classes or across different disease areas, across different geographical jurisdictions, you see quite quickly that there is suboptimal interoperability between the different databases and the different sources that we receive. And so we're doing our best to facilitate discussions on classifications and standards, and just getting some basic level of harmonization on the sort of metadata for what's collected in different areas really could lead to a lot of payoffs in the quality of the information that we have for decision making. Just a little bit on the visualizations here. As I said, you really need to go into the website and do this. But if you go into the funding information, here this is funding across all the different disease areas that we have. Here by product category, and here over time. So all of this is interactive. You can click on, say, HIV, and then this turns into the HIV-specific product breakdown with trends over time. You can click on medicines, and then all of this turns into what is the medicines R&D investment breakdown by disease and over time. Or you could just look at, say, TB medicines or malaria vaccines, and then it would be specific to that. Just one high-level point I wanted to raise, which I think is quite concerning, that comes out of the most recent G-Finder, which is if you look at their definition of overall neglected infectious diseases, which would include TB, malaria, and some classifications of HIV funding, it peaked at 2009, and it's flatlined and it's been reducing since then, which is, I think, really concerning. And as everybody knows, there was this peak in the Ebola-related funding following on from 2014, which was appropriate that we needed that. But I think we all need to be making the case that that we need continued investment in these diseases which are killing many, many people every day. In terms of the products in the pipeline, this is one of the areas where I think the dialogue between the different disease areas and the different sources will help us in the harmonization between classifications and how we present this. For example, at the moment here, this refers to vector control products, where the way that the evaluation of vector control products is quite different the way that it's described to drugs or vaccines. But at the moment, we have 352 different candidate products across 23 disease classes that are being tracked in vaccines, medicines, diagnostics, and vector control, and we continue to expand this. For clinical trials, as I said, we're visualizing this global database that we have. So far, this is up to 2015. We're going to be including the 2016 information as soon as we can. So this has 342,976 clinical trials, which you can visualize in interactive ways. You can look to see what has been the trend for any one particular country over time. This is the only place in the world that you can do this. So if you want to know what clinical trials have been happening in France or Germany, this is the only place where you can do it. Because if you go to clinicaltrials.gov or the EU registry, they have their trials. This aggregates, let's say Germany, this aggregates all the German trials from all of these different places in one place. And I think you can immediately see some very interesting trends in flatlining in some of the richer countries for the total numbers of clinical trials, contrasted to, for example, China. If we were connected to the internet, you could see that it looks like it's not even linear. It's sort of going at the moment like an exponential increase in the numbers of clinical trials. So if that continued, it's a big if, but if that continues, then China would be the single country in the world with the most numbers of clinical trials each year within about 5 or 6 years. You can also see that the commonest disease condition is cancer overall, which I guess isn't surprising. We're also being transparent about problems in data quality because we think this is very important, and we hope that we can drive improvements in data quality. So surprisingly, to me at least, there's still a large number of trials where we can't, with a lot of confidence, assign what the disease condition is, which should be something that we can do. So we're in discussions with the clinical trial registries about how to force disease condition assignment when clinical trials are registered. In terms of publications, you can look by topic and see the geographic distribution over time for publications. And soon to go up publicly, we're working with NIH and others on the World Report data source on grants that are made, grants by different funders, 2 different settings, by region, by country, and also to different recipients. So that will be available soon. So all this provides information that then leads into the disease-specific analyses, which we're generating according to a standard template with all of these different axes of information that I've talked about. The public health goals, the available tools, the limitations, the R&D flows, the product pipelines, the TDR product profile directory. And we're going to be asking groups we're commissioning these comprehensive disease-specific analyses, working with the relevant WHO department. Those are going to be provided to this expert committee. And the first meeting of the expert committee, the outcome is going to be to go through a process of the possible approaches to R&D prioritization, the best practice methodologies, and agreeing the standardized methodology that they're going to be applying. And we're going to be transparent about the whole process of how we do this. And we're going to be presenting to them the malaria disease-specific analysis as an example. And then we're going to be going through different disease areas and coming out with really comprehensive global R&D priorities, not just we need a product, say a drug against X, but the R&D agenda that we would consider at the global level really is the gap for where investments need to go with the end-to-end perspective. So, what do we need ultimately in order to improve public health, focusing on the public health objectives where the needs are greatest. So, just to wrap up, the R&D Observatory provides one comprehensive source of information and analyses on key health R&D activities that is reviewed and quality assured by WHO. Priority setting for new R&D through the expert committee provides an independent, impartial and evidence-based approach to set global priorities based on public health needs. And between the observatory and the committee, we will move to a point where we'll have a common approach that is available for the funders who would be interested in what a comprehensive global set of R&D priorities would be that is comparable across diseases. And the way that I see this, different funders have different scopes and strategies, but if you have, and I have worked in a funder previously, if you have a credible, coherent, comprehensive, independent, most importantly, process which lays out at a global level what the R&D priorities are, it would allow each individual funder within the scope of their activities to have more confidence that they are really adding to the bigger picture. And so we would expect that many funders would find this helpful. And another aspect of this is that it could be, and we would need to work on this, it could be adapted beyond the global setting to regional or national decision-making where, say, middle-income countries are interested in really having all the information at their level to make decisions about their own national R&D priorities. So I'd just like to gratefully acknowledge the funding support from our donors, the European Commission, the government of France, Germany, Switzerland, and the United States of America, without whom we couldn't have done this. Thank you very much.
Thank you very much, Vazi. This was actually the first time that the results of the WHO R&D Observatory were presented here in Geneva in this form, since the report is just fresh off the press. So basically, you were the first ones to basically see some of those results. I now have the great pleasure to invite Robert Terry to come to the podium. Robert is a knowledge manager, special program for research and training and development for tropical diseases, TDR at WHO. And when I asked Terry, what is it that drives him? It was interesting to see that he said, well, basically exactly what Vazi is presenting. We need a transparency and an openness completely increased so that the data can really enhance R&D. If we do not share those data, we won't be able to go far. So Terry, please welcome.
Okay, thank you everybody, and good afternoon. Do we just move the slides on ourselves? Yeah. Great, thank you. Okay, so I'm speaking to you today as part of TDR. TDR is a special program that's hosted by WHO but co-sponsored by UNICEF, the World Bank, and UNDP. We've been around since the 1970s, supporting research capacity and product development. In fact, you might be aware of one of our alumni has just been elected the DG, so we're quite pleased about that. So just to say why TDR is speaking in this space, because of that long history of working in research and development, we were requested by the World Health Assembly to explore what the potential could be for a financing mechanism under the WHO. And this is part of this now legendary CEWG follow-up process. But essentially, I am somebody that has actually been following that process for I think about 15 years now, so I do feel like I know it quite well. But the suggestion was, Within WHO, is there a role for member states acting together collectively in the coordination of an R&D fund in order to achieve accessible and affordable prices? As we've heard, that would mean really delinking the R&D costs from the final price. Other things that seem to get lost along the way is also support for new ways of actually undertaking R&D. So innovation, collaboration, different ways of sharing and sharing data. And that, as I said before, or said on my behalf, that's something that really drives me. With the creation of the internet now, we have absolutely no barriers to sharing information and data, and we really do need to think about different ways of utilizing that. So we were asked to come up with a mechanism that could operate, and we produced this report in March of last year. There are copies outside on the table, and what this really presents is a practical, credible model for how a pooled R&D fund could operate under the governance mechanisms of WHO. We also were thinking of, if you had a pooled fund, how would you actually manage the portfolio of products? And so we were looking at different tools for measuring that, and that's really where product profiles come in, and that's what I'm going to focus on. And we were asked by the member states to then say, okay, if this fund came into being, how would it operate? What would it look like? And so we were asked to come up with a couple of disease-based studies, and we've done that. So there is a new document now available which actually shows the workings, or at least the prospective workings of this funding mechanism using leishmaniasis and schistosomiasis as examples. And all of that will be discussed either later this afternoon or possibly tomorrow under agenda item 13.5 on today's World Health Assembly. So within that report, we did a lot of work. It's an incredibly difficult and I think almost impossible question to answer, which is how much money do you need to fund product development. But we did create a tool which gave us a number of options for if you had a pooled fund, how would that actually make a difference. As we heard, certainly in the 1990s, or the beginning of the 1990s, there weren't really that many initiatives in global health R&D. Now there are many, many thousands. So how much money would be enough to actually make a difference? And we were offering to the member states that over a period of about 7 years, you would need to be running a fund at around about 100 million a year, supporting between 25 and 40 projects. And if we'd started now, by 2017, we may have 2 or 3 repurposed drugs. We may even have a new chemical entity that we could bring to market. This is a model. It's lots of different ifs, buts, and maybes, but it's one of the few out there that actually, rather than tries to say the cost of an individual drug, what is the cost of actually running a portfolio? And if you have a portfolio, how do you actually manage it? How do you identify your priorities, and how do you communicate those priorities? What sort of tools you need? And as we were going through this, I realized that there's quite a lot of information that is out there, whether it's by WHO or whether it's by companies or others. They actually write down and create these documents, product profiles. They're often called target product profiles, but not many of them are in the public domain, and certainly they're not very easily accessible. So one of the things we decided to do was to try and collect these and bring these together. And the reason for this is I was speaking to quite a large number of pharmaceutical industry about 3 years ago, and we were using the what seems to be a fairly standard argument now, that the main problem for creating drugs, vaccines, or diagnostics in this area is market failure. And the pushback which came from industry was, yeah, okay, but what about the public health failure? And the public health failure in actually describing in clear and articulate terms what your priorities are and what needs to be done. So taking that on board, we've now spent the last year or so trying to map these product profiles and try to use them in a way that can actually identify where work is going on and where there's gaps in that work. And in time, and as you've seen with the creation now of a sort of global resource with the R&D Observatory, once you have that type of information and you can start to triangulate between different data sources, we may well be in a much better place to have greater precision in describing what our priorities are, And if we can actually agree on those, then there is a slight possibility that we may move closer towards coordination, which is what everybody seems to desire. People always say they like coordination, but nobody wants to be coordinated. We've spoken to hundreds and hundreds of different people. What we've now discovered is that these product profiles are in many different forms and many different formats. It's not surprising, but we will actually move forward now, I think, in trying to create some standards and some harmonization around that. And as we've sort of put this together, we've now created a directory. And this directory will contain, at a high level, in the same way as the International Clinical Trials Registry Platform does, enough information for you to understand what the profile is describing, but not so much data as to be overwhelming. And also, this is a directory, right? It's not the sole source of information. But what will this allow us to do? Well, here are some very exciting screenshots of the directory. It'll allow you to search on different diseases and by different efficacy and those types of things. I am really going to skip through this because we can get to the main point, which is you will then be able to find in summary form the different profiles that are out there. Now, there are some interesting aspects to this. So, for example, at a global level, we might legitimately require or want that WHO is articulating these priorities, and that may well be where we end up in a lot of these areas. But we need to separate between what's being produced by WHO and what's being produced by others, and we'll clearly be able to do that. What I think, for me, that's really interesting is you'll be able to see for the first time, I think, and quite quickly, who's producing these profiles, the products. These are prospective, when it was published, what is the indication, what is the target population, what is the efficacy. Here's another example for Chagas. But I think the value of doing anything like this is actually when you start to think about priorities and really the topic of what it is we're trying to talk about today, which is how do we identify what priorities are, particularly at a global level and working across technologies and working across diseases and working across countries. It's exceptionally difficult. This is an illustrative table. It's not exactly the situation, but even from the very early work that we've done, it's fairly clear that the agenda for the observatory and the expert committee is going to be quite large. There are lots of areas where we don't actually have a clear idea of what the priority looks like for a therapeutic or a diagnostic. There are some areas where there may well be work that's going on, but we haven't actually clarified what would be considered to be the sort of global norm in this area. So this is just taking the type 3 diseases, those that are prominently found in developing countries. This is type 2, those that are found more globally, but the burden of diseases in developing countries. And again, these are illustrative diagrams, but you can start to see, once you aggregate this type of data, you can start to have a little bit of evidence to inform the conversation about where we should start to make priorities, where are there gaps, where are there work that needs to be done, whether it's looking across technologies, whether it's looking across diseases. And in time, and as the observatory grows the data set that it has, and as I said before, if you start to triangulate this type of information, you can do these sorts of things where you're plotting activity against R&D funding and disease burden, and you can start to assist in that sort of conversation about how priorities are made and how they're undertaken. So this is the types of things that we're seeking to do. So the directory will be a directory. It'll point you in the right direction. It'll signpost you in that area. It will be a tool to highlight gaps and areas where it's working. What it isn't, and certainly is not at this stage, is any kind of endorsement from WHO about what is and isn't an appropriate profile, but that may well come in the future. It isn't linked to procurement, although I say that, and that's why UNICEF is in brackets. Actually, UNICEF is actually saying its product profiles is linked to its procurement process. Now, if I think about the CWG process, that's quite an interesting idea, because of what we actually there have is a really strong pull mechanism for R&D linked to an outcome, which is procurement. So there's many things that will have to happen as we move forward. The reason we haven't gone live with the directory as we wanted to before this assembly is that as we talk to more and more groups and organisations, there's a strong interest in this now. So we've collected what we think already exists within WHO, but UNICEF, UNDP, Global Fund, Gates Foundation, many of the PDPs also want to start sharing this type of data with us. So we want to build a critical mass. Industry is a bit hot and cold on this, perhaps not surprisingly, because certainly once you get into the specifics of a target profile, then you may have a lot of proprietary data in there, and it may not be so useful to have at this type of level. And at the moment, we're focusing very much on diagnostics, vaccines, and therapeutics, but there's a strong interest to think about medical devices, other equipment, say vector control, treatment regimes, and those types of things. So just in summary, because in a sense, as I said, I have been working with this CWG for many, many years. How does this all fit together? Well, from certainly a couple of years ago, the incentive of this from the member states was like, if we wanted to get involved in R&D funding, how would we do it? Now, what we've got is a mechanism that could work for them. I can't think of any other I could cross, or T that I could cross, or I that I could dot, or any other document I could write which could explain any clearer how a mechanism could work for the WHO if it wanted to do it. We have, I think, an initial and excellent facility in the R&D Observatory. As you've seen, for the first time, we're actually being able to bring together at a global level the data that's necessary to try to make global decisions. And we have an expert committee that we put together that, again, I think for the first time in many, many years, we'll be able to decide and describe what the priorities are at a global level. Whether or not a fund comes into being, that is still an exceptionally useful activity. And if as I said, the report that I mentioned earlier, if you wanted to see more about how this may work, then please do read this. It's perhaps worth saying we were introduced to this particular session, saying if anyone can put their hand up and say a session that was sponsored by South Africa and the EC and the Swiss. Well, one of the things that's happened as a result of this is that we have been running some demonstration projects. And I have to say, this is the first time we have actually got funding into that pooled fund from South Africa, from India, from Brazil, as well as Switzerland and Norway. Now, again, I'm not aware of a global initiative that's funding R&D that takes money in from those sources. And the reason I mention that is because I think there is still worth pushing, and I will still try to do it, as to why a pooled fund that can access new money from different donors, and this isn't the standard European, North American, and the two big foundations. We're talking about other countries here. So there's a real role within this mechanism for disease endemic and donor countries. I think the G20 countries are sort of really talking now about their commitment to the NTDs, and this mechanism would be an ideal resource for them. You could see pooled funding from the BRICS countries, from countries in sub-Saharan Africa, which could actually bring new resource into this space. As Vasi mentioned, one of the concerns right now is that funding for the neglected diseases has been stable for the last 4 or 5 years, and in actual fact, if you take Ebola out of the equation, it's falling. I think we now have a mechanism which links global targets and priorities with a mechanism to take action. The focus for global R&D means we can take steps towards greater coordination. The pooled funding arrangement is a good idea because you can have many donors, but one process, and that's in efficiency, and essentially you're sharing your risks and therefore shared success. And we have many people, many mechanisms within WHO and certainly within TDR where we could just build on the experience that we already have. So we don't have to reinvent the wheel. Even though we already have, it seems, created many, many new mechanisms for funding R&D in the last few years, we could certainly adapt this one to meet those. So thank you for that. Again, mostly what I've presented is the work of many, many people, many teams. Ryoko's in the audience here. ISIS is also here working with me. And all of this was enabled and funded by the Swiss Agency for Development and Cooperation. So very grateful for them. Thank you.
There will be, don't worry. There will. No, don't. I don't. So thank you so much, Terry. I have now the pleasure to invite to the podium Kevin McCarthy, who is the Senior Health Advisor of the European Commission Europe Aid. Kevin was present 10 years ago when the negotiations went on for the both of the Global Strategy and Plan of Action on Public Health, Innovation and IP. And he's been working with the EU Commission, and so welcome to the podium.
Good afternoon. Happy to see you were able to escape the Palais and come down here where it's nice and cool and relaxed, but for a very important topic. Because in actual fact, what we're discussing here will be of major interest to many member states up at the Palais when they come to the agenda item on CEWG, that famous acronym, later on today or tomorrow morning. So let me just pull up the slides. So I'm one of those probably in the room that isn't surprised by CEWG. I won't go, Rob is probably another one. Precious, definitely, if she was here, would have made it a threesome. I presume there are more in the room. But actually, all those years ago, we were looking at a global strategy and plan of action. And the CEWG was actually one product of that. And in that context, it created a space for us in the Commission to take some initiatives to support the work that was expected to be carried out. And I think major progress has been made on that. But first, let me thank Alexander for tirelessly pushing this side event. He floated the idea back in January at the EB. In actual fact, in the EB, he acknowledged the support of the EU, the Commission, in the way we were supporting the observatory. So we're very grateful for that. But also Rob as well, in his tireless enthusiasm and energy, and making this a reality today. And thank you, Tanya, as well, for introducing us. And I understand I'm between you, the questions, and then something to eat. So I'll try to be brief, but keep it relevant. So I'm not a researcher, I'm a civil servant. But in my DNA, as a civil servant, I have the CEWG and the Global Strategy and Plan of Action written there. I did work in health research funding, but have moved to the development side. And these are our aims. We're talking about health systems, we're talking about a country perspective, we're talking about how we use those instruments to develop a country. We are not a mandated research organization. So what are we doing here? Well, in actual fact, our sister service, DG Research and Innovation, has that responsibility. They have a mandate, they have a program. Many of you are aware of it. It's often referred to as framework programs. Framework Program 7 was the previous one. Framework Program 8 is referred to as Horizon 2020. And I could spend all day, probably the next few days, if I had the right slides, briefing you about Horizon 2020. My colleagues couldn't be here. But that's not why I'm here now. I don't want to talk in particular about the research funding mechanisms. I want to make you understand how we were able to influence the agenda from a development point of view. But to give credit where it is due, I will be touching on the structure of the Horizon 2020. My important message is that we have in our European institutional family, the European Parliament, who has taken important initiatives to stress access to medicines and affordable medicines. And this has allowed us to take action and promote an agenda that is not normally one that a development agency would promote. In an ideal world, I would say yes, but the world is not ideal. So you will find this information. It's in the latest GFinder report. The EC, through its programming, is one of the largest public funders of research and development. There's a big debate about what should a public funder do with the results, with the patents, with the IP on that. And this is also something that's very much discussed in the European Parliament. It does have an impact on the way in which global health is funded. My colleagues are active in many different ways. They have a governance structure and rules of participation of Horizon 2020 that dictate a certain pathway for consortia to come together. They cannot simply pick hundreds of millions and put them to a side and say, yes, this is what we will give you to do what we should be doing in the first place. No, it's working around those existing procedures, those existing contexts, to take the best out of the funding instrument, in this case Horizon 2020, to work with, for example, one of the initiatives, recent initiatives on vaccines development, CEPI. There are some principles that sometimes are forgotten. There is certain conditions in certain areas in which consortia must address the concerns of the countries in question. A longer-term perspective rather than a short-term partnership approach. We too maintain that in discussions with our colleagues that it must be a partnership approach with low and middle-income countries. I haven't mentioned it here in the slide, but excellence is a key criteria for the Horizon 2020 program. From a development perspective, excellence isn't necessarily the first one on our list. However, when you look at the funding mechanisms and the funding results and the initiatives, it's a major amount of funding influence on the market, with industry, with private public ventures, responding to outbreaks, the Ebola, the Zika outbreaks, the way in which a new approach to responding to emergencies can be developed through an actor like the European Commission. And I know my colleagues are very active in this work with colleagues in WHO. They feed that to us, to the results. However, they are still within a funding mechanism that cannot be adapted overnight. And this can only be addressed in a new future funding program, FP9, if you wish, that will kick off after 2020. So one of the items that Alexander thought, and I thought might be of interest, is the way in which the Commission works with other entities and other processes. Okay, we have the processes that they set up themselves through the EDCTP, another famous acronym for some of you, European and Developing Country Clinical Trials Partnership, also the Innovative Medicines Initiative, and CEPI, and even TDR through the work plan of the EDCTP. But one interesting part of the work that is actually influencing that global health priority setting agenda is the work of the G7. Will have major implications for how the observatory can move forward. Now, it is entitled Mapping, Coordination and Other Joint Activities. And as Rob said, nobody likes to be coordinated too much. And I think the tasks that are being managed by the working group are quite difficult. A continuous exchange of information, but what kind of information, on what basis, what type of strategic research agenda are we talking about, what kind of data is being used or promoted through these groups. And I think it's important that the work of the observatory, and in TDR in particular, making that transparent and open can only enhance the work here of the G7. The G7, by its very name, would suggest that perhaps they are less open. This is hopefully not the case. They need to be more credible in demonstrating what they are able to do with the data out there and not be working in isolation. Now, a common problem is the interoperability of databases, and this is something the G7 working group have set themselves the collaboration with the existing initiatives is going to be critical to arrive at a sensible way forward to have that interoperability. I'm not going to say much more on that. They do want to think outside the box. They're looking at the way in which a G7 prize can be developed. Prizes were actually one of the first products or the first thinkings of the CEWG in the first report that we had suggested that could be taken up and was taken up in Horizon 2020. There's a prize on AMR, for example, and also a prize not yet completed. The process is still ongoing on maternal and child health. So there is new thinking, and the G7 can contribute to that process, but they shouldn't be working in isolation, in my opinion. So basically, I come back to where I am from a development funder, donor perspective, and how we see action initiated by European Parliament, concerns, wishes that are formulated through a budgetary allocation to take forward work on access to medicines. And since 2007, they've been highlighting this, even before, but in particular 2007, a lot of fresh funding was made available. And at that time, it was scratching your head, well, what do we do with this? Development was not a research organization or a mandated organization, but you had at that same time the development of the Global Strategy and Plan of Action, GESPOA, another acronym. You will recall it was to promote new thinking in innovation and access to medicines. We've come a long way. I think that more needs to be done on the innovation side, in particular how you define innovation, because for me it is much broader than just simple product innovation. But it is to move away from a purely market-driven approach and then looking at how you target diseases which disproportionately affect people in developing countries. There was about 17 million euros that was made available at that time. And we have a number of projects that have now come to an end. One on local production and technology transfer. It was mentioned by a previous speaker. In particular, it has influenced the way in which Ethiopia has tried to bring its industrial strategy closer to its public health needs and concerns. The work has been done, for example, in looking at the advantages of how Cuba tackles the issues in certain reports produced by WHO. We also have the work of WHO TDR, I always put the two together, to generate evidence and increase access for poorer communities in lower middle income countries for health interventions, because the global strategy was not just about research, it was also about the health systems and interventions and approaches and networking. Their primary healthcare workers and case management were focused on. It's come to a successful conclusion last year. Another one you may have come across, some of you, I don't know if Solomon is in the room, but the ANDI project, African Network for Drugs and Diagnostics Innovation. This was also looking at the way in which you could see the work of ANDI being extrapolated to kickoffs in Asia and Latin America. They work across the board, have in fact been the recipient of one of the demonstration projects, but sadly the funding has not materialized in the way it should have done. And then many have said, a lot of this would not have taken place if there was no EU funding, and I'm afraid that's true. The 17 million has gone a long way in providing seeds that some have grown into some flowers, beautiful flowers, and mighty oak trees, I would say, in some cases. Without that seed funding, you wouldn't have had that progress today, I believe, to the way in which TDR is addressing the issues, and that you have the Global Observatory, as we witnessed today, setting out what is possible in an open and shared way. Parliament has continued its prioritization of access to medicines and made available another 1.5 million in 2015 and a further 1.5 million this year to take forward that work on the Global Observatory and the innovation platforms that is managed through WHO Essential Medicines Department. We hope more than hope, we believe that this is a very strong way forward. Yes, we are one of the major donors. We don't expect to be the only donor or continue to be the donor in the future, because this project must demonstrate its value. For me, that has already happened, but it needs to make a success outside certain circles that go beyond the interested few. For example, up the road at the WHA, when we talk about access to medicines and affordability. Access and affordability are key for us. It's something we advocate all the time in our discussions with industry on one hand, but also our sister and brother services when we're talking about research. And some say, yeah, it can't be done. Well, research is there to at least attempt a way around the problem and discuss possible issues. This is what we believe in through a development lens where research has to make a difference. That policy context is critical. It is about poverty eradication, and the priority setting must reflect this. But the context is critical. We need research and innovation, and social innovation work that's been done by TDR is important here because it gives a different perspective and brings in an important sector that sometimes feels a little bit left out, the private sector. It should be about a comprehensive way forward, not just a very simple disease-specific way. But we have to realize we're in a real world. Those resources are very scarce. How do you prioritize? And a key part of our development policy is about universal health coverage. And there you have people, services, and users. We saw that yesterday, if you were around, at the launch of the new compact on universal health coverage. This is key to our policy. We are heavily committed to that work, but it's something that drives our policy in all areas. So thank you for your attention, and hopefully take some questions later.
Good. So we're going to take questions, and I already see hands up. So let's take a few questions. The lady over there. And we've got running mics, so... Is it okay if I take 3 questions? I'll take 3 questions at a time. Okay. Go ahead. Can you please introduce yourself and state your question, please?
Hi, Grania Brigden from the TB Union. I represent a project that the Union are involved in along with the government of South Africa on looking at a new funding and incentive mechanism for the development of new TB drugs and regimens in line with the CW principles that Rob had on his slide regarding delinkage and affordable access. And this is looking at generating a large pooled fund to enable the development of new TB drugs and regimens. So my question to the panel is that this initiative, like others, the GARD-P, for example, are all looking at pool funding for R&D. And so how do initiatives like this fit into support, or maybe not support, the overall ask of a global R&D, a global pooled R&D fund? Thank you.
Thank you very much. Can you please pass the mic to the gentleman over there?
Yeah, this is Sebastian Schönherr from University's Allied for Essential Medicines. Mr. Howell-Friede mentioned the Bayh-Dole Act and the role it played, or the importance it had when it comes to licensing things that have been researched at universities. So I've been in touch with a lot of universities actually, and I've been trying to convince them to adopt social licensing guidelines, since that is one of the things we at University Allied for Essential Medicines do. And one response I've gotten often is that actually the universities don't get a lot of money from selling the patents, but why it is important for them to patent and to sell patents is because patents as publications are one of the factors that decides on how much funding the university will get. So I'm wondering where you see the role of policymakers and funders, and what you see as a possible solution for this problem.
Thank you very much. And we'll take the question here of the gentleman in the front. Can you please pass the mic down?
Thank you very much. Boris Engelson, a local journalist freelance accredited with the UN. The topic here is based on evidence. And you know as well as I do that evidences have got a bad name lately, increasingly so. So I can show with very simple examples why we are going to argue on which evidence proves what through which figure until next General Assembly. Here is a Canon camera. I doubt very much that Canon devotes more than 10% of its research expenses to the specific needs of the poor countries. The same for the seats you are sitting on. But the Graduate Institute spends probably half its resources on specific problem of the developing country. It's even in its name, Institute for International Relations and Development.
Can you come to your questions,
So
please?
my question is, why do you try to brainwash us with wrong evidence, which will be a subject of controversy, which I am quite ready to go on in spite of the late hour until tomorrow morning, if you want.
Thank you. I'll take you afterwards. So can we first go to the questions with the lady regarding TB? Rob, can I give it to you? It's okay.
Is it on? Okay, fine. So, in a sense, this is the 3 Ps project, Grania. Thanks for raising that. This is a really important question. I mean, even in the last 5 years, I could probably count maybe 10 new initiatives that have been created, whether it's GHIT, CEPI, Global, GLOPID, CARBEX, all of these new initiatives, all focused on R&D, all focused on salami slicing the sort of R&D agenda into different disease types and specificity. Now, there's one way of saying that this isn't helpful because it, as with the title of this whole discussion is around, is that this fragments the agenda. And yeah, I think a simple analysis might say that's true. However, there is lots of specializations, and TB, I think, is absolutely one of them, where there is a concentration that's needed to be brought to bear, and there's a focus that needs to happen. So I don't particularly think if there is a will and there's a way of accessing funds that wouldn't necessarily be accessed, and for TB that might be the case, if you particularly look at some of the BRICS countries, well, where you have incidence, high incidence, then I think these initiatives need to be welcomed and supported. Where I hope we actually get better, and I think the takeaway message, I think, from this initiative is that WHO is now providing, I would say, the evidence, which isn't really manufactured in any way or biased in the sense. It's providing transparency. And through that transparency, we can agree what those priorities are, and then we may well then lead to greater coordination. So I think that would be my response to how these initiatives fit in. They are self-generating and they're often supporting specific targets. But as we improve with the transparency and the sharing of data, then I don't see that necessarily as a particular problem at this stage.
Thank you very much, Rob. I'm going to give the mic to Martin to answer the question of the gentleman on the IP and patents issue.
So You're absolutely right. So you're spot on. I'll just give a few explanations around it. We had a meeting at the Institut Pasteur with the American University transfer officers, with the NIH, with the Europeans, Chinese were there. And it is clear universities are now doing a lot more to say, if we take a patent, how do we use the patent in such a way that it does not make a barrier? So if you make a patent on a car that drives by itself, we don't worry about how you license it. But if you have a patent on a drug to treat a cancer, a drug to treat an infection, whatever, this must be managed in the way which ensures access. So the universities are becoming very good at this. Where it's become a little bit of a problematic issue is when university individuals within the university are taking out patents on things where, quite honestly, the university would say, this isn't going to bring us much money, but there's a drive. And in some countries, they even get a little bit of a kind of points reward for having a patent. It goes on their CV. So there is a little bit of managing the individuals there. The universities are doing a lot better, but it has created a barrier in the past, and we are only now beginning to tackle that barrier. And the way that your group is working on it, we're in touch with them. It's very effective.
Thank you very much. I think Vasi wanted to add something to the questions regarding TB to the lady. So, Vasi, please.
Hello, TB lady. Just to add to Rob's question, answer, I think another way of putting this is that there are always going to be decisions to have multiple different initiatives. And that in itself is, there's no problem with that. But where we would like to get to is that we have all of the information out there to get us to the point where we have information sharing and we have, as far as possible, an evidence-based joint decision about what all of the needed activities are to get you from where you want to get to. Now, the first step is that. Actually, the first step's before that. I think the first step is having information sharing. Second step is hopefully where we can get to with what is this initiative with the Observatory and the Expert Committee, which is agreement, evidence-based agreement on everything that needs to happen in the R&D space. Now then, how that is implemented is another discussion. And I think the most ambitious folks would, argue, but people don't agree on this, that some people would say ideally you'd have some kind of coordinated mechanism where, with a lot of governance, and everything is done through one mechanism. That is a step above. I think there's a very important sweet spot where you can have essentially a joint strategy and individual implementation, but absolutely aware of what the other players are doing, avoiding unnecessary overlap, maximizing efficiency. If we can get to there, that is major progress.
Thank you. We have time for one more round. I want to go to the lady there. Yes.
Thank you very much. I would like to commend the speakers because I was very involved also in the GSPOA. I was at that time the expert of the NDI following the entire negotiation, so you will recognize my face. I have to thank you because my skepticism of the last few years about all these tools that sometimes may appear as a bit of a destructive mechanism to look at the GSPOA in its entire version has been reduced after today's presentation. So I do appreciate the meaning of these tools. However, I have two questions here. Does the WHO's role into this whole lengthy game, which started in 2003, I guess, officially when the CIPIH, is just to, produce these tools and produce this evidence, or do we need WHO to do more? And my second question connected to the first one is, what is the linkage between this huge and lengthy exercise that the WHO is performing and pursuing with the other 7 elements of the GSPOA? because we have all focused on element 7, but there are 8 elements. So can you please tell me more about the connection between this tool production and the policy context, which the Bayh-Dole Act case shows is just as important? Thank you very much.
Can you pass the mic to the lady in the front, and then we'll take the gentleman here.
Hello, my name is Kathleen Weiss, and I work for Cochrane, and I wanted to just comment on some things I heard in the course of the panel today, and the words like prioritization and synthesis and evidence and independence and transparency. My organization works in evidence-informed healthcare. We produce systematic reviews and other synthesized evidence, and I have 2 things. One's a comment and one's a question. One is, if there is a way that we can contribute to this process, please know that that's something we'd very much like to do. And the second is, what is the role that you see for synthesized evidence playing in this process?
Thank you very much. While we pass the mic to this gentleman, did you want to answer?
So I will try and answer your question. So first of all, it's quite a provocative question, so I'll give a fairly provocative answer. We think we're not trying to brainwash you. What we would like to do is brainwash the funders. And to brainwash the funders, we do need to come up with evidence. But if I go back to my opening line about the 90-10 division that was spoken about in 1990, what was the evidence for this? This was a couple of guys sitting around drinking beer, said, well, we think it's about this and it's about this. So actually, we didn't really know that it was 90-10. Was it 90-10 or 99-1? And what is it now? I can't tell you. I don't think Vazi can tell you. I don't think Rob can tell you. Are we 90-10, 80-20, or 99-1? So we need numbers. And we need these numbers to be, as just been mentioned, transparent and reliable. So, and then we can brainwash the funders. That is our real objective.
See, so you were not the target. Good. Thank you. Sir, do you want to ask a question? Well, do you have a question to ask? Yes, go ahead.
I can go. Yes, thank you very much. I am Riyad Baja. I'm an international consultant following international negotiations in the UN with the observer status. But I will be brief and concise in my intervention. But first of all, let me mention what you didn't mention, and I will share that with you briefly. Those working group and committees. How about the tripartite meeting, WHO, WIPO, World Intellectual Property Organization, and WTO, World Trade Organization? We are still talking and just talking since 6 years ago, and with the support, of course, state members and the other coordinators, Mr. Zafar, your colleague in WHO, it could be a useful committee, expert committee, and official document. And Mrs. Dania, certainly she can do her best nowadays, as she did previously in the UN committee in UNGAS, isn't it? Yes.
Did you have a question?
My question, I go directly to my questions about patent. If we have to see the crescent or the statistic, not since 1990, but since 1995. Why? The new technologies and application of new technologies on biology, mainly. You see, some pharma company, they patented, they have product on behalf only one molecule, they have many products. And in 95, TRIPS agreements have been adopted and it is administered by WTO. This observatory, very useful global observatory, those 10%, my question on 10%. Usually companies, they have dedicated only 10% on their budget for R&D, because we should be aware about that. Sometimes 10%, it could be less, it could be more. This is my questions. Thank you very much.
Thank you very much. I'm going to give the floor to Rob to answer the question of Cochrane.
Yeah, not the patent one, that's good.
Yeah. No, I'm trying to actually go in ping pong, but making sure that we answer all the questions, but I want to, speed it up.
And I may well combine that with the other question that was around the sort of coherence across the GSPOA, the Global Strategy Plan of Action. I mean, there's a relatively simple answer to that, which is, I think it's agenda item 13.4, which is the evaluation of the GSPA. So that paper can give you a summary of all of the elements that have been progressed through WHO, and what we've been trying to find out is what member states themselves have undertaken stimulated by that strategy. So rather than give a long answer, I point you to that paper. And in terms of the evidence and synthesis, I would say, well, one of the things that was stimulated by this process, and in 2005, and again with initial seed funding from the EC through TDR, was the establishment of a network of evidence-informed policymakers, which is very much around local context and taking evidence and using that to inform policy. And that network still exists today. It's active throughout AFRO, PAHO, the WHO regions there, and EMRO. And so, in a sense, we work very much with the methodology of Cochrane, but also the methodology that comes out of, say, the Norwegian Institute of Public Health and GRADE and those types of activities. So, yeah, very much so.
Kevin, you wanted to add something on the GSPOA?
Yeah, sure. I mean, one of the concerns we had was to take the strategy as a whole with the privileged funding from the European Parliament, because this was not in our programming, it was not part of the normal committee meetings that you would find normally with member states. This was ad hoc. So we felt we had to do justice to the strategy, not just one individual. So I believe out of the 8 elements, at least 3 or 4 were being addressed, from capacity building to priority setting to local production, transfer of technology, as well as health systems interventions. So I think we're one of the few that have actually stepped into those, at the time, icy waters, because there wasn't much enthusiasm. I think the waters have warmed up slightly, not just because of global warming, but because we've made a lot of progress since then. I think the evaluation that Rob referred to will demonstrate the value, because we don't really see it. This is one of the few opportunities that we're actually able to talk about it. There was another point. No, I'll leave it there at the moment. Yeah.
Martin, can I give you the floor regarding the 10% question?
So, interesting question. So first of all, come back to the tripartite WHO, WTO. This was a very useful activity, and I'd like to link this to element 4 of the GSPOA, because we had a big activity on element 4, which was technology transfer, which was a deliverable within that. So we spent a lot of time working with manufacturers in developing countries, with companies. So we've looked at what is the R&D investment, and it goes anywhere from 0. And this is a problem, because in developing countries, we've got some manufacturers that are producing at very low cost, but 0 reinvestment in R&D. This is not sustainable. And so we are pushing the price which we want to procure things so low that the companies cannot reinvest in R&D, which makes them unsustainable in the long term. And this goes through, let's call them the multinationals, the famous GSK, Sanofi's, etc. It's 15% plus or minus. And then we come to the biotech companies, what we call the translational. And then it is 80, 90, up to 95% reinvestment, because this is their livelihood. So what is the ideal number? It depends on where you are in the development, but we do think that 15% reinvestment in R&D is probably the minimum that you need to become sustainable. Now, of this 15%, how much of it is R&D relevant for the topics that we're discussing here? This is where we need to bring the coherency between the industrial policy and the health policy, because it's a lot more cost-effective to reinvest in something that's going to generate this than in something that's going to generate good health.
Thank you very much. We've actually passed over time, so I invite you to actually talk to the speakers when we're over. When Kennedy spoke to NASA in 1960, he said, "I'm giving you 10 years to put a man on the moon and back to Earth." It actually took 8.5 years for the NASA to execute that dream with a deadline. In the area of R&D and neglected tropical diseases and this whole fragmentation landscape, we are actually still building the first part of our launching machine. And I always say we've got to have a sense of urgency here. And so the purpose of this panel was really to wake us all up. And when I say us, it's governments, it's stakeholders, it's the one who can make a difference. And this afternoon, we are going to continue the discussion at the Assembly on this topic, and we really hope that we can continue investing in the R&D in a less fragmented way, and that we really hope that all the data that you have provided us with the Health Observatory, with the Observatory on R&D, will help us making much more informed decisions. I've passed time. There are sandwiches and drinks upstairs for you. Thank you so much for coming here. We'll try to operate in the best way possible to the Palais des Nations to be on time. Thank you very much.